So our last plenary talk, Dr. John Ayers, getting the public back in public health.
Oh, thank you for having me. I really appreciate being here. So I'm talking about public health, which is dramatically different than healthcare. You know, we've been typically talking about doing it kind of one at a time, or maybe doing it one at a time within a system. And I want to talk about how we can get the public back in public health. Now, when I went to school, I was taught public health was how to save lives millions at a time, to change systems, and do research that can find action points to impact the public. And I really thought that was public health. But it turns out I was way, way wrong. That's not actually how public health works. And like all good lessons, I learned my lesson from watching TV. And so one Sunday I'm watching football, and I guess I was a little too lazy to change the channel. And after the football game came on 60 Minutes. And Leslie Stahl was talking about a snooze pandemic that was going to come. Now, how many people in the room have ever heard of snooze? Exactly, I hadn't either. But apparently there was this pandemic. It's not an infectious disease. It's a tobacco product. It's like snuff you put under your cheek, and you use it. And they're like, "Whoa! Everybody's going to be using this product." I'm like, "Man, I work in public health. I've never heard of this." And she's talking about all these issues, and it's a full 30-minute, half hour of the 1-hour program talking about this snooze pandemic. And I'm like, what is going on there? So I go to everybody's favorite website, which is NIH Reporter, where we report on who's getting funded to do research on what, when, and where. And I look for snooze, and I find, man, we're spending a lot of money on snooze. And I've really never heard of it. So I start looking at these studies, and all these studies are like from the typical standard model where we've already been doing research, like how do we help people quit using snooze? How do we monitor snooze advertisements? And nobody's asking the fundamental question, and that is, are people even interested in the product? Are people using it? And at the time, we began working with Google, and so I went to work the next day, and I pulled up some data. And here's some data looking at aggregate internet searches across the United States. And what you can see is there in snooze, the black dashed line, it was already somewhat popular, but long ago, and had been declining in popularity now for about a year and a half, even though the pandemic is just starting. But while I was looking, I found this other product, and back then we called them electronic nicotine delivery systems. We didn't call them e-cigarettes because nobody knew what they were, but that product was getting way, way more interest, about 30-fold more searches on Google, and it was actually increasing over this period, not decreasing. And I thought, man, if we're upset about a snooze pandemic, what are we going to think about this? So I started digging deeper, and it turns out, actually, this wasn't just the United States. It's a worldwide phenomenon. This is many, many years ago. And everybody's interested in e-cigarettes. And I'm like, man, we got to get this message out there. We got to teach people about this, because if everybody wants to know about the snooze thing, they're going to want to know about this. And so I remember I shared these exact same figures. And I sent it to the top medical journal. And within like 2 days, they're like, get the hell out of here. We're not interested in this. And I'm like, but wait. Did you see the 6 Minute story about snooze? This thing's way more popular than snooze. And I kind of argued with it. And I remember the lady who was the editor then, she told me, she's like, well, my husband is in a jam band. I've seen people use snooze. I've never seen anybody use an electronic cigarette. And I thought, oh my God, that's the model we have? And so we fought, and eventually published our study. And it became one of the most popular studies that year in medicine, because people were interested in this new system. And of course, when you went on NIH Reporter, there was a lot of grants now being written on e-cigarettes, but what did we do? We did exactly what we did with snooze. We didn't ask the fundamental questions. Instead, we took our already existing model and applied it to e-cigarettes. And that is to say, using an e-cigarette will cause you to do what? Want to smoke a Marlboro Red. Now, this was one of the most read studies in JAMA the year it came out. Is this remotely true? You don't need data to know that. How many people you see start using an e-cigarette and switch to Marlboros? It does not happen, period, full stop. But yet, this is a quality of data we have. And why is that? It's because we have this top-down driven model where we, the experts, we already know what the problems are, and we know the solution. We're that smart. And so therefore, we don't respond to data. And so we view everything from our existing prism, and we can't pivot in a way to actually impact public health. Now, you might be thinking, well, John, you told me this one story. This can't be true of a lot of things, but it turns out, formally, that's true. Most published findings are false, and most of these published findings are immaterial to actual public health. They make no difference on decision making whatsoever. I mean, to give an example of this, I was speaking the other day at a conference, and the guy who got up before me, I guess he was embarrassed. I brought this up then, I'll bring it up again now. His speech was on how 40% of students at an elite university were food insecure. A university costs $80,000 a year to attend. And I'm like, what is he talking about? Is he crazy? And it turns out, he's like, John, the data don't lie. And the survey is, have you skipped a meal in the last week? I mean, that's called intermittent fasting. I do that every day, even though I'm fat. So apparently I'm rich and fat and food insecure. It's quite the fiasco. And so what I want to do today is try to help you deviate from that model. Reject this top-down driven model where we know the problems, we know the answers, because admittedly, none of us know this. Nobody knew what the market cap of Tesla would be 5 years ago. We can only deal with what we know now. And so what I want to do is instead embrace a model where we spend more time listening to the public and respond to those needs and listen to them where they're coming and already sharing their voice out in the wild on the internet. Now, I told you about our e-cigarette story, and I told you it was a bit of a failure, that study, but I also believe that this type of approach can make a difference. And so I want to tell you a little different story than what most people do. I'm not going to tell you about my research and about how we made money on it and how I bought a new car and a bigger house. I want to tell you about how we did research that actually impacted the outcomes, actually achieved a measurable difference in public health outcomes. Now, the first story is one that happened a few years ago with Charlie Sheen. Now, this is from the Today Show when Charlie Sheen announced he was HIV positive. And it was at the top of the hour, and I like to pretend I watch fancy TV, but I don't. I watch the Today Show. And so I saw this, and I thought, man, this is really interesting. And Matt Lauer's not asking Charlie Sheen about public health questions like, how do you get tested? Like, should you get tested? Who's at risk? And Charlie Sheen's like, he's not voluntarily talking about public health angle. And I'm like, well, this is interesting. I remember when I was a kid and Magic Johnson was HIV positive, like, you didn't know anything. People were like, can you shake his hand? He'll be dead in 4 years, right? But for 20 years, when Charlie Sheen made his disclosure, we were getting a consistent message. ABC, always be careful. Use condoms. Get tested. Be aware of the signs and symptoms. HIV, acute infection, will present as like a flu. So be aware if you have those symptoms, you've been at risk, maybe you should go and get tested. And so I went on the websites and I saw nobody's talking about this. Nobody. I'm like, but clearly something's happening here. And if you look at the data, yeah, a lot of people were interested in HIV. So here in blue is news stories about HIV. Here in black is internet searches on Google about HIV, just anything that has the word HIV. And those went up dramatically, about 250% higher than what you'd expect for news articles talking about HIV, and 400% talking about just people searching for HIV. But I remember that always be careful, right? So even though we're not talking about this, even though this is an organic event, could the public be responding in a meaningful way? And it turns out they were. Now I'll start here with the middle example. So here you're seeing in D and E, we have internet searches for like HIV symptoms and internet searches for HIV testing. And both of those instantaneously, these are searches by minute, increased as soon as Charlie Sheen made his disclosure. And they were statistically significantly higher for about 3 days. Now the top panel is condoms. Now not many people are thinking about condoms at 9 a.m. They're way less interesting to me. But it turns out it follows a very strong circadian pattern. So that night when they began thinking about sex, they began going online going, I need to get some condoms, around 10 p.m. And that effect was similar. It lasted about 3 days. And so here we can see the public actually engaging without being primed by just simply observing the event. By listening to them, we can see how they engaged and how potentially improved their health. Now, when we did our study, it was very popular in the news. Of course, it's about Charlie Sheen. It has nothing to do with me. And Charlie Sheen was nice enough to comment on our study. But what could we do to take this micro effect and turn it into a macro effect? And I remember I used to go on the Dr. Oz show. Yeah, I know I'm one of those misinformation guys. And Michael Croupian was the CMO, and he's like, John, Charlie Sheen comes on here a lot, and I was on there once talking about Charlie Sheen, and they're like, what could we do? And I'm like, let's do a condom commercial. So we did a condom commercial. And so you can go on YouTube and find condom commercials. I'm in some of them, even though I'm a Baptist kid from North Carolina. Don't tell my dad. But we did a condom commercial. We promoted this new condom that was very expensive. That won like an X Prize for condoms. And we brought that to market. And so we used this Charlie Sheen effect to create like an echo effect. Take that micro effect and make it a macro effect. Around the same time as our study came out, I remember an executive at OraSure, which is the maker of OraQuick. OraQuick's an over-the-counter HIV testing kit. You can buy it at Walmart, Walgreens, wherever. He reached out and he's like, John, we get barcode data, but it's delayed, quarterly, because it's publicly traded companies. We can't share Walgreens or Walmart's data, but we can give it to you when it comes out. I'm like, that's great. Well, what do you think we're going to see, right? Why is Alphabet a multi-trillion-dollar company? Because what you search for is what you actually do. And yes, the lowest level aggregation internet searches for people buying HIV test kits that week reached an all-time high similar to internet searches. But I told him, I'm like, I'm not interested in that effect. I know Charlie Sheen's the all-time high. I get that. What's the effect of our study? And it turns out if you look at over-the-counter HIV testing kit sales, the third all-time high is us. We're multiple times bigger than National HIV Testing Days. I think Charlie Sheen was 7 National HIV Testing Days. We were like 2. We didn't need millions of dollars. We needed to plan 5 years in advance. We just listened and responded. And the public understanding that we hear them, responded again. And how do we make this sustainable? How do we make this type of monitoring sustainable? One of the things we're doing here at CalIT2, working with Ramesh, is to build systems to make it so everyone can do this type of research. So if you go right now on your phone on hivtrends.org, you can download real-time data on HIV testing sales so that people can monitor these outcomes to then respond accordingly. And we're working with various groups to make sure that they can also identify events like this and respond. Another example when we did this was with Pokemon Go. Now, everybody, who remembers Pokemon Go? I'm not a big player, but I remember it, and it was a huge thing. And lots of people who are smarter than me, like Atul Butte, were saying things like, this is great. I love it. People are going to get rich and healthy. Give me some of the money. But, that's what he was saying. And everybody was saying that. And I remember watching this, and I'm thinking like, I love to win. But I'm not very fast. So if I want to win and get all the Pokemon before you do, I'll get my fancy red sports car, and I'll drive real fast, and I'll beat you there. I'm like, how do we see this? How do we see this effect? So a week after the game came out, I'm like, how do we do it? We have accelerometer data on your phone, but we can't get that. Apple's not going to give it to us. Google's not going to give it to us. Samsung. But what's one thing everybody likes to do on the internet? And why is it Twitter so popular? People love to tattletale. And so the first week after the game came out, we had 350,000 tweets talking about playing the game and driving. And here I'll walk you through some examples. So here are drivers where it's like, oh my God, I'm catching Pokemon and driving, or my mom just legit stopped the car to catch a Pokemon and ran across the road. Passengers talking about how they're playing and their friends are driving around, like my mom's driving me around to catch Pokemon. Or pedestrians talking about how, they saw someone get hit by a car or almost hit by a car playing Pokemon. And of these, 350,000, about 1/3 suggested that the driver or passenger or pedestrian was playing and interacting with traffic, like a real world safety signal that we didn't expect. Unfortunately, the corporate world isn't out to get us. So when the CEO of Niantic, the parent company, reached out, he's like, how do we fix this problem? So we explained to him, like, listen, you have access to the App Store to the accelerometer data on your phone. You can just make the game not playable once you get to driving speeds. And of course they did it. And some state legislators codified into law standards that said augmented reality games have to include these safety restrictions so you can't play it in your fancy red sports car driving around real fast. You have to get out and walk and get the good that Atul Butte thought everyone would get. Now, I've talked to you about successes with this type of framework, this type of bottom-up framework with public health. Sadly, sometimes there's going to be failures, and I'll tell you about one. This is a good friend of mine, Howard Kopelitz. He runs the Child Mind Institute. And I'm not a big Netflix guy, but I remember he reached out and he's like, John, there's a show coming out based on a popular book called 13 Reasons Why. Who remembers the show? And so the show, for those of you who don't remember, is about a high school girl. It's a high school drama based on a novel about a girl who commits suicide. And it's about her path on suicide. Now, WHO, the World Health Organization, has very strict guidelines on how we talk about suicide in the media. Why is that? Because copycat suicide. It's actually one of the strongest, population effects that you can observe. When a celebrity commits suicide, for example, single occupant motor vehicle crashes that result in fatality statistically significantly increase. When a celebrity commits suicide, single occupant general aviation fatalities increase. And so we can look at death records and see these effects over and over and over again. And so the WHO developed these guidelines to say, how do we minimize that effect? And so what do? You don't talk about the modality. You don't frame suicide as a solution to your problems. You don't say that suicide was like something that you would expect, that was an acceptable outcome. And 13 Reasons Why broke all those rules. The show opens up. The protagonist, the lady who's killed herself, she's already dead. You see a camera zooming in slowly on her locker, Wooded Memorial. Yet she goes to the prom. Her boyfriend regrets being mean to her. Her parents, they really, really have a much better relationship with her. Suicide solved all her problems. And I remember trying to get this message out there, and Howard did some work trying to get it out there, and we couldn't. And so we waited for the show to finally come out, and during the first 2 weeks of the show, we looked, and here's internet searches that contain the word suicide. And so you can see internet searches that contain the word suicide, they increased above what you'd expect. And we're like, man, we got to have a conversation about what to do with this show. We got to do something different. And people were like, well, John, that doesn't mean much. Like, you just say people searching for suicide, they could be searching for the suicide helpline. So I'll show you a random sample of exact searches. You can see here, like suicide chat, National Suicide Hotline, those statistically significantly decreased after the show came to air. But what increased? How to suicide. How to kill yourself, up 15%. Commit suicide. How to commit suicide. How to painlessly commit suicide. People actually thinking about killing themselves. We're directly observing the phenomena. Now, I remember when our show came out, when our study came out, I'm like, well, I think we're all going to get together here, right? We're all going to get together and be on the same team here. We want to help people. But that's not what the experts in the top-down model say. Sherry Pagotto, the head of the largest clinical psychology association in the United States, she said, this study does not demonstrate the show causes suicide, just Google searches, which is not all that surprising. Sean Young, who wrote several books on the topic of suicide in teens, he says, it's important not to get freaked out. The show isn't causing anybody to kill themselves. And what did Netflix say? They say, we always believed the show would increase discussion around a tough subject matter. We couldn't see the data until it slapped us in the face. If that was Sherry's daughter, would it just be people talking about suicide? If that was Sean Young's son, would it just be a dialogue? And I remember when I was doing some media on this, is before COVID, you had to go down to the studio downtown. And you sit there in a dark room like this. There's a camera right there where you're at. You're wearing the earpiece and you're hearing what's going out live on the broadcast, as they're checking your levels. And the person talking before me was a dad who said he found his daughter dead by suicide. And on the screen was, do you want to continue watching this program? I thought, my God, I could barely do the interview. People actually being harmed, and we can directly observe it, but our top-down model won't let us say it. We tried really hard to get this problem fixed. A friend of mine who works in the entertainment industry, he set us up to meet with Netflix, and it was just, because we went to Netflix meeting, guess what they said? He said, all these experts in the news comment on your work. They said it's an important conversation. So we got them to add a warning label to the show. It took many weeks to get them to do that. But the sick thing is what did the top-down model do? They wrote requests for applications for grant funding. They said, we want to do more research on this. And so they sat around for 646 days before their model could respond and show that people actually showing up to ER with self-injuries indicative of suicide had increased in the same time period we talked about. It does not matter then. The harm has already been done. And I was surprised that the journal let us do this. We told them to go fuck themselves. And we said, listen, if you can't respond to data in a meaningful way, what are we doing here? This isn't some esoteric dialogue. And you know, during COVID, we heard a lot about parachutes, but we heard a lot about a talk about how we're going to be data agile. But think about it. What was all that in service to? The powerful, the people at the top of the top-down model. We never embraced the bottom-up model. So here at the Qualcomm Institute, how can we fix this problem? How do we fix this problem? And I think one of the ways we can fix this problem is by thinking about how to make public health sustainable as an enterprise. All these great ideas you heard about before, they're all accessible for venture capital. I can see ways you can monetize that outcome. You know, Kristen just talked about ARPA-H, right? That's for creating companies. That's why they're giving him money, is to do startups. But how do we make public health monetizable? How do we create the infrastructure where we can have data and make data actionable? And I think that's something we can definitely do here. And so I kind of alluded to this before, my apologies, but one of the things we can do is by building systems to make this data available. So I told you about Charlie Shing. Here's an example of, like, in black is actual testing cells. Here in blue are individual searches for people searching about HIV testing kits. And we can build a model that can actually predict that. Even though the sales data is restricted, you can't get access to the data. The data is long out of date by the time you get it. We can build models that can nowcast that, and we can get it within pretty good accuracy. If you look in the bottom right-hand corner, we can predict actual weekly testing sales within plus or minus just 250 kits. So we can predict it very, very well. And so we can take data where we only have data available in black, that's all the public has, and we can use nowcasting techniques to make all that data prospectively available. And when you do that and you have that framework, it's not about identifying events that are face obvious, it's about identifying events that you don't anticipate. So here in red, on each one of those nodes is an outlier. And we used a threshold that was, very insensitive to identifying outliers, and I think we have 22 outliers in this example. Of those 22, 60% were to events that you know about, like National HIV Testing Day or World AIDS Day or a celebrity. The other 40%, no idea. Like the last red model there in the far right in 2023, that's actually people going out and buying HIV testing kits because there's news articles talking about an outbreak of HIV in rural New Mexico from vampire facials, where they take little needle pricks and exfoliate your skin. And the person that used the needle before, they had HIV, and several people got HIV. But that drove people to go buy HIV testing kits, and we wouldn't be aware of this either. And so you can go there to get that data. Another way we can do it is change the way we do traditional data. So in healthcare and public health, all of our data comes from cohort studies, like the famous one being the Framingham study. And what a cohort study means, we follow like a community long term, and we learn about them. And that's where all our great data comes from, like antihypertensives being great for reducing mortality, or learning all the bioplausible mechanisms that impact your health individually and also from public health perspective. But cohort studies are kind of hard to do. I mean, you have to go really take over a whole town and do it. And the ones we have are all like 60, 70 years old. We're not starting new ones. Well, what if we started cohort studies not in the town square physically, but in the digital town square? And here I want to show an example around vaping. So here in black are bars showing that, like, where we look at one individual and how many times did they tweet where they had the word vaping in it. And you can see thousands and thousands and thousands of people tweet 10 times, 12 times, 20 times when they tweet about vaping. And so now we have repeated observations of that one person over time. And what does that look like? Well, we can create 43.8 million person days of observation from this data. That's the largest cohort study ever done by a factor of like 12. So we have all this rich data, and now we can zoom in on individuals and see how their public health is impacted. And here's an example of one lady where you can see on the first time she tweets, she's like, I got my vape today. She's so happy. She's like, a few days later, 24 days later, she's like, I hotboxed in the car. But then we see like a couple months later, she's like at the dinner table and her dad's like, do you need to really be using that thing all the time? But she's still excited about it, right? 52 days later, she's like, my vape's pretty stunning. I love it. But then you see about 150 days later, she's like, what happened? Something's going wrong. I don't know if this vape thing's doing what it needs to do for me. And then we see shortly thereafter, she's talking about how her vape died, and she's still got 3.5 hours at work. So we see her talking about her addiction, how she's addicted. And she continues to talk about that. But she's still kind of hot for vaping, right? I mean, 200 days later, she's like, my vape is pretty freaking hot. I love it. But then, almost a year later, we can see her say, when I started vaping, it was just for fun, I guess, but now I'm really addicted to nicotine and I need help. And then a few days later, 461 days, she's like, every time my vape dies, I get a vape, it breaks after 2 months. It's God telling me to quit. Her first time she's thinking about quitting. She's like, I really should stop vaping because I'm starting to wheeze now for a month. So we can see adverse events. So look at all this data-rich data. You talked about collecting data on an individual over time. Look at all this data-rich data we have. We can see what she's thinking and when she's thinking it and how she's evolving around vaping. And we can directly observe those phenomena. And we can use that to study events like cessation behaviors and like see how, people in this cohort make attempts. Who announces they have an intention to quit? Fewer, but most people spontaneously make a quit attempt, about 12% of people. We can see if their attempt was successful or not to quit vaping. We can see if their second attempt was successful or not, the third attempt. We can see everything about them through this cohort. And so we can move traditional cohorts to a digital cohort by building out this infrastructure to actually help people. Thank you so much.